Hi, this is Dr. Al-Swad. I am presenting to you on how to engage with large and supportive guide. This is a trick became helpful in so many ways in the left main and in the RCA when I needed a very supportive guide, but I couldn't engage it for some reason. Either the guide is too big, or there's orientation, or the orientation of the ostium is really weird. So there is a case to illustrate this. This is a patient with RCA-CTO, severe three-vessel disease. We treated the left main LAD and left circumflex previously. The left circumflex was also CTO, but we treated it. We treated the RCA previously and it failed, so we ended up doing a STAR technique, and she came back 2 months later and the RCA as if we never touched it. And if you notice here, there is a lesion right at the ostium of the RCA. We engaged with an AL1 8 French guide catheter, and every time I tried to advance the wire wouldn't go. I could use actually supportive wire, but that means I'll dissect the RCA and shut this marginal branch, and then we'll end up with an RV infarction because this is the only marginal branch she has, and I did not want to risk that. So what to do when you cannot really engage with a large guide, or you engage and you cannot advance the wire. So you need more coaxial engagement. And what you can do in this situation, you actually use a diagnostic catheter that everybody is familiar with, JR4, that could engage more coaxially. So in an 8 French guide, you can put a 5 French diagnostic catheter. You could put 6 French sometimes, and the catheter has to be longer than the guide. There are diagnostic catheters that are 110 and 125 centimeter. I didn't have them, but my guide is 90 centimeter, so I took the co-pilot and or the watchdog and actually advanced the JR4 5 French through it. And if you notice here, I have a really very short segment, but I was able to engage and take a very good picture with excellent coaxial engagement. So now if you're trying to advance, this, what's gonna happen, you're gonna push the guide and the catheter gonna just pop out. So you have to put a wire. And this is 5 French diagnostic JR4. So we put a wire in here, and this wire has to be 300 centimeter. Sorry, everybody has to have it in the lab. So 300 centimeter wire, just a workhorse wire I used to run through here in this situation. And then it became a little bit tricky to advance the guide over this. It will be awesome if I can put a balloon here, inflate it, so I anchor the whole system. But if you put a balloon through the diagnostic GR4 catheter, first of all, this is hard, and second, you're not going to be able to pull the diagnostic catheter. But there are other tricks. So what I did, basically, you just have to simultaneously pull and manipulate the guide in the same time. And here the guide is kind of moving. The guide moved here, so the worst thing is to pull. So instead we pushed a little bit. We pushed and then torqued it, and we were able to basically engage with the wire. So this RCA-CTO, the rest of it was kind of history, what we did. We put an anchor balloon in here, 2 millimeter. I crushed the proximal cap with this balloon, and then used Confianza Pro 12 to puncture the proximal cap, and then de-escalated immediately to polymer jacket wire. I used radar wire, which went immediately in the subintimal space. I put a Stingray balloon. By the way, I tried Stingray balloon last time. It didn't work. But this time I put a Stingray balloon, inflated it, if you see here flat, and I took a Confianza Pro 12 with a CTO shape and a secondary shape, and it performed 3 sticks. And after performing 3 sticks, I took basically a Pilot 200, which flew into the true lumen after a little bit of manipulation. And if you notice here, we are proximal to the bifurcation of the marginal branch, but I was worried about losing the marginal branch. I took confirmatory orthogonal view to see that wire is actually in the PDA, and it was. I did not show you here. And then we simply stented actually into the PDA, which led to the loss of the posterolateral branch. Because I am sure I stuck and the dissection plane was actually proximal to the bifurcation when from my stingray picture, it was only like a kind of hematoma shift and a plaque shift. So it was wired so simple with the microcatheter. We wired it and basically end up with this. I did actually drug-coated balloon here. There is non-flow limiting dissection. I want to limit stenting. So, and we're stenting from the PDA to the ostial RCA. So these are, this is one of the tricks how to engage with the guide. This trick actually is easier to perform if you are using EBU or XB or VODA in the left main system. This trick is even easier. You take a JL4 guide catheter, that actually the system kind of lends itself easy. And this way you guarantee you have a good guide support without compromising your guide support, and so you can engage. And if you couldn't engage, you can do it you can do it just to engage with the guide catheter. If you